Hearts go out to his wife, Dr. Kelly Martin, his two children, Tess and Jacob, and just take a moment of silence just to recognize Tony's legacy. Well, thank you. So let's now turn to our first of two great speakers. We were very fortunate this year to recruit Dr. Jeffrey Ishizuka. Jeff is an assistant professor of medicine, and Jeff's work previously at Harvard was focused on the biology of T cells, discovering a better understanding of that biology, and ultimately leveraging that science to what is likely to be the next generation of immunotherapies. And we're really very fortunate to have Jeff as one of our physician scientists in the Center of Molecular and Cellular Oncology, a member of the melanoma program, and physician scientist in general at Yale and Smilo. So Jeff, really excited to hear about your work. Turn it over to you.
Thank you so much, Charlie. Really appreciate it. And let me just protect my slides. There we go. Yes, thank you so much. And thank you for the opportunity to speak today. Today, I'm going to be talking to you about some of the work we've done targeting double-stranded RNA in order to overcome immunotherapy resistance, and also update on other ongoing projects in the lab. This is my disclosure slide. I wanted to begin with the overall survival curves from the Checkmate 067 trial, which is likely familiar to this audience. These curves represent survival in advanced melanoma by patients treated with immune checkpoint blockade, in this case with antibodies targeting PD-1, CTLA-4, or the combination. I wanted to start here because melanoma has been something of a touchstone for the use of checkpoint blockade in solid tumors. The first indication approved and remains one of the indications in which immune checkpoint blockade is most effective. And these data are outstanding, particularly when compared with the pre-immunotherapy standard of care dacarbazine, which had an overall survival of 5 to 10% at 5 years. However, even in this disease, a large proportion of patients don't experience a durable benefit, a situation which is actually more challenging in other diseases where the responses are less good. And this is really the focus of our work, to improve responses in this disease and in others. Certainly, however, immune checkpoint blockade is rapidly reshaping the landscape of cancer care across indications. I was preparing for this talk and I had to go through and update this slide because indications have nearly doubled since its original publication by Tony Ribas and Jed Wolchuk in 2018. Although many of us have followed this emerging data very closely, I have to admit that it gave me pause to consider the pace of change in this field. The advancement of PD-1 axis approvals continues through lymphomas and solid tumors of disparate tissue origins. Combination approaches have also proliferated, including approvals in mesothelioma, breast cancer, and others. Successful combinations include combinations of checkpoint inhibitors with other checkpoint inhibitors, chemotherapies, and tyrosine kinase inhibitors. And notably, many here at Yale have played critical roles in this advancement. Still, for all the advances, there have been a lot of failures, and there remain a lot of ongoing challenges. Foremost, many patients don't respond. Indeed, considered across all indications, most patients don't respond. And a few of the response rates listed are really based on earlier trials that likely overestimated response rates. Many of them also include biomarker cut points, PD-L1 positivity, and this sort of thing. And in my mind, there are really a couple of big areas in which we can improve. First, for all of the new indications, few combinations involving novel targets have been approved. Second, we have a limited mechanistic understanding of how these agents work. Accordingly, the biomarkers that we use to deploy them lack sensitivity and specificity, and there's not a great way to rationally prioritize combinations with anti-PD-1. So it's worth considering for a moment what we've learned about response and resistance. Not so much in the interest of an extensive overview, for which we wouldn't have time today, but in terms of the pathways that have given the strongest clinical signals to date. The data shown here are from a study by Merck of over 300 different patients across 22 different tumor tissue types. These figures show responses and non-response defined as CR or PR versus no CR or PR. When graphed with tumor mutational burden on the y-axis and a gene expression profile representing tumor microenvironment inflammation, kind of T-cell inflammation, on the x-axis. The genes in this profile are listed in the upper right here, and notably include PD-L1 among them, as well as several MHC-related genes and kind of T-cell-related genes. Tumor mutational burden, as you know, is often used as a surrogate for tumor neoantigens, and the gene expression profile really points to inflammation of the tumor microenvironment. And the authors make 2 points that are important here. First, that these are 2 of the strongest predictors they could find, reviewing one of the largest and most comprehensive data sets that existed at the time, and really it still exists. And second, that they appear to predict response independently of one another. That is to say that although the best responses are in that kind of upper right quadrant, that you actually get a good number of responses in a T-cell inflamed only microenvironment or in TMB only, TMB high only tumors. For the sake of time today, I won't spend a lot of time on TMB or antigen load, though it's obviously an important consideration. Instead, I'm just going to talk about tumor microenvironment inflammation, which is really the focus of our lab. Aside from the work by the Merck group, a number of lines of evidence have established inadequate tumor microenvironment inflammation as one of the most prominent mechanisms of resistance to immunotherapy. Most dramatically, this occurs in immune desert type tumors, which entirely lack T-cell infiltrate, as depicted here. However, it can also occur in a different phenotype, the so-called immune excluded tumors, which have anti-tumor immune cells at the site of the tumor, although they are excluded from the tumor core, either by physical barriers or by immune signaling. Finally, we believe that there's the T-cell inflamed type of tumor that have diffuse infiltration of T cells that tend to be PD-L1 positive, and these are the ones that we believe respond best to immunotherapy. To date, there's been progress in identifying therapeutic strategies to enhance this tumor microenvironment inflammation, many of which involve either real or simulated infection of the tumor to trigger anti-tumor immunity. And I think about them in kind of 2 big buckets. The first is the provision of exogenous sources that mimic nucleic acid ligands to tumors. This includes STING agonists, MDA5 or RIG-I agonists, double-stranded RNA sensing pathways, and oncolytic viruses. The other is the induction of endogenous sources of nucleic acid ligand, primarily endogenous retroviruses, although others have been published recently, ALU repeats in humans. Examples of this include azacitidine and CDK4 and 6 inhibitors. So my interest in turning these cold microenvironments hot and kind of providing these ligands to tumors really developed out of work in Nick Haning's lab while I was finishing my postdoctoral work there. And through the type of experiment that I'm showing here. On the left, you have kind of a transplantable tumor cell line, something like a B16 melanoma. And the way the experiment works is to infect that cell line with a library of CRISPR-Cas9 guides that knock out thousands of immunologically relevant genes in the genome. And then to kind of select those guides until you have a pool of knockout tumor cell lines that is then implanted into mice under increasing immune selective pressure, from extremely immunodeficient mice that lack T cells to mice with an intact immune cell system to mice treated with immunotherapy. In this case, the irradiated GM-CSF secreting whole tumor cell vaccine GVAX plus anti-PD-1, kind of strong immunotherapy treatment regimen. We would grow these tumors for about 2 weeks and then remove them, harvest the tumors, and sequence the barcodes, sequence the guides, using them as barcodes, and quantitating enrichment and depletion of each guide. And the way we interpreted this experiment was to compare high to low immune selective pressure, so immunotherapy treated to immunodeficient mice, for example. And to interpret it that guides that were depleted, comparing high to low immune selective pressure, represented genes that, when deleted, confer sensitivity to the immune system, and therefore potential targets for combination immunotherapy. In contrast, guides that were enriched under strong immune selective pressure suggested to us genes that, when lost, made tumors resistant to immunotherapy. And a lot of the targets that we found this way actually ended up in the kind of realm of double-stranded RNA sensing or antiviral triggering. And this is really the area that I focused on throughout my time. And this got us thinking, because a lot of what we know about viral infection comes from the study of exogenous viruses. But of course, the genome is comprised largely of repetitive elements that have the potential to form double-stranded RNA. These could be small interspersed nuclear elements, endogenous retroviruses, or long interspersed nuclear elements, or others. And so we considered that we've co-evolved with these elements, with these kind of viral remnants in many cases. And our cells have developed systems to regulate double-stranded RNA sensing, to distinguish between double-stranded RNA that's a result of normal cellular activity and exogenous viral threats. And so we thought that by targeting some of the genes that control this regulation, we might sensitize tumor cells to immunotherapy, trigger this kind of antiviral state. And the top hit that we discovered through this process in the antiviral sensing arena was this gene, ADAR1. ADAR is an adenosine deaminase that acts on double-stranded RNA. It has a long cytoplasmic P150 isoform that's interferon inducible, and a short constitutively expressed P110 isoform. The main known function of ADAR is to catalyze the conversion of adenosine to inosine in double-stranded RNA. And it's thought that in so doing, it prevents double-stranded RNA sensing and the triggering of antiviral immunity, kind of autoimmunity. Accordingly, there is an autoimmune syndrome called a Cardi-Goudier syndrome that is associated with biallelic mutations of ADAR1 in the catalytic domain. It can be quite severe. It affects children and mimics viral infection. However, interestingly, the parents of affected patients who have monoallelic mutations in the catalytic domain have evidence of increased signatures of interferon gene expression in the blood, but have no detectable disease phenotype, suggesting that there's a gene dose effect. So to begin to validate ADAR1 as a potential drug target for combination immunotherapy, we created dedicated knockout tumor cell lines, again using the B16 melanoma model, this transplantable tumor model. And we implanted these into mice under increasing selective pressure, immune selective pressure, starting with the extremely immunodeficient non-SCID gamma mice that entirely lack adaptive immunity and have only impaired innate immunity. In these mice, looking at the ADAR null tumors, either P150 knockouts in orange, P150, P110 knockouts in red, compared to controls in gray, and looking at tumor volume on the top or survival on the bottom, you can see a sort of minimal decrease in the growth of the ADAR null tumors compared to controls, and a minimal increase in survival. In contrast, when we implanted these tumors into wild-type mice with an intact immune system, you see a significant decrease in the growth of tumors and a significant survival advantage for the mice. Finally, when we implanted these tumors into mice and treated with anti-PD-1, we saw a near 100% cure rate for the mice treated that were ADAR null, and almost no cures in the control tumors. So to start to understand the mechanism of this, we looked at the tumor microenvironment of untreated ADAR null and control tumors 14 days after implantation. And we did this using immunohistochemistry. And as you can see on the left, in control tumors, you have the immune desert type phenotype, almost no CD8 T cells infiltrating. In contrast, in ADAR null tumors, we saw this T cell inflamed phenotype with diffuse infiltration of CD8 T cells, quantitated here on the right. To understand this more deeply, we next performed flow cytometry, again with tumors 14 days after implantation in the untreated setting. And as you might predict, we saw an increase in CD45 positive immune cells in ADAR null tumors compared with controls. And then looking within the CD45 compartment, we saw increases in CD3 positive T cells, CD4 positive T cells, CD8 positive T cells, gamma delta T cells, and NK cells. In contrast, when we looked at immunosuppressive populations, including MDSC and tumor-associated neutrophils, we saw significant increases in control tumors relative to ADAR null tumors. Finally, to probe the microenvironment yet more deeply, we performed single-cell RNA sequencing. These are the populations we recovered, with myeloid populations in the upper right and T-cell populations in the bottom left. As you can see, using these density plots that we adapted for this purpose, you get a strong signal from suppressive myeloid populations, M2-like macrophages and MDSC in control tumors, but a weaker signal from inflammatory monocytes and CD8 T cells. In contrast, in the Adarf null tumors, you have hardly any signal from the suppressive myeloid populations and an enrichment of signal from inflammatory monocytes and CD8 T cells. To understand what's driving this change in the microenvironment, we wanted to study the double-stranded RNA sensing pathways that we thought could be associated with the phenotypes we'd observed. Specifically, we wanted to understand the role of protein kinase R and MDA5 RIG-I and MAVs, which are both associated with as internal sensors of nucleic acid and double-stranded RNA specifically. Protein kinase R is associated with translational arrest and apoptosis upon binding double-stranded RNA, whereas MDA5 RIG-I and MAVs induce type 1 interferon in the antiviral state. To test the role of each of these sensors, we generated a series of double and triple knockout tumor cell lines and probed some of the in vitro phenotypes that we'd previously studied in Adarf null tumors. Specifically, we looked first at growth inhibition. So when you stimulate control tumors with interferon in vitro, there's a slight defect in growth that's magnified when you knock out ADAR1. Looking at our double knockouts, we saw no effect of knocking out RIG-I, MDA5, or MAVs, but saw that knocking out PKR reduced the phenotype to the levels observed in control tumors, suggesting that PKR was alone responsible for the in vitro growth defect that we'd observed. We next looked at interferon beta production. This was again an in vitro ELISA in tumor cells stimulated with interferon. As you can see, control tumors produce no detectable interferon, whereas Adarf null tumors produce a significant quantity. This is maintained following the loss of RIG-I, suggesting that RIG-I is not involved in the phenotype. However, following the loss of MDA5, MAVs, or PKR, you see a significant reduction, suggesting that all three of these sensors, or these two sensors in this adapter, have a role to play in the phenotype. We next wanted to understand which of these double-stranded RNA sensing pathways was required for the in vivo phenotype of sensitization to immune checkpoint blockade. So we took our double and triple knockout tumor cell lines and implanted them into mice, treating the mice with PD-1, antibodies targeting PD-1. And as you can see in our control experiment, control tumors continue to grow out as they did previously for us, and the Adarf null tumors respond well to immunotherapy. This phenotype persisted following loss of PKR, suggesting that PKR is alone not required for the phenotype. Similarly, it persisted following loss of MDA5, suggesting that MDA5 alone does not explain the phenotype. However, following the deletion of both PKR and MDA5 together with ADAR1, we no longer observed any difference between the growth of ADAR1 null and control tumors treated with immunotherapy. Together, these results suggested to us that growth inhibition by PKR or antiviral sensing by MDA5 and MAVs is sufficient to mediate sensitivity to immunotherapy, but that at least one is required. We next wanted to understand which double-stranded RNA sensing pathway was required for the enhanced immune infiltration, for the inflammation in the tumor microenvironment that we'd observed. And so we again used our double and triple knockout tumor cell lines, and this time returned to our habit of looking at the tumor microenvironment, dissecting the tumors out, separating out the cells, and quantitating them to look which sensor was required. In our control tumors, you see a relatively low infiltration of immune cells that significantly increased following loss of ADAR1. And interestingly, this phenotype is, if anything, exaggerated following loss of protein kinase R. However, it's attenuated following loss of MDA5 and ablated following the loss of the two sensors together. A similar pattern followed when we looked at the proportion of CD45 positive immune cells that was comprised of CD8 T cells. Again, increases in Adarf null that persisted following loss of PKR, was attenuated following loss of MDA5 and lost following the loss of both sensors together. When we looked at immunosuppressive MDSC, we saw the opposite pattern, increases in control that persisted or were even increased further following loss of PKR, and a loss of the phenotype following loss of MDA5 or the two sensors together. This suggested to us that MDA5 may be playing a predominant role in inducing tumor microenvironment inflammation in Adarf tumors. To confirm this, we looked at the production of interferon beta and interferon gamma in the tumor microenvironment of the Adarf tumors. And we saw a similar pattern again, increases in Adarf tumors that persisted following loss of PKR, but was lost after loss of MDA5 or the two sensors together. And the same pattern again, looking at tumor lysate interferon gamma. So having seen this powerful dual mechanism for sensitizing tumors to immunotherapy, we asked whether loss of ADAR1 was sufficient to overcome commonly acquired mechanisms of resistance to immunotherapy, including genetic aberrations that have been identified as enriched when comparing discordant responsive pre-treatment and resistant post-treatment lesions matched from the same patient. Known mechanisms that fit this description include the loss of MHC-I through mutations of HLA or beta-2M, loss of target antigen expression through immunoediting, and mutations in interferon sensing pathways, including interferon gamma receptor, the JAKs, and the STATs. And we focused first on the loss of MHC-I as mediated by loss of beta-2 microglobulin, which has been repeatedly identified as an important and challenging form of resistance. To create this model, we again used CRISPR and Cas9, this time deleting beta-2 microglobulin and ADAR together, along with creating matched control tumor cell lines. To validate our model of resistance, we compared control in beta-2M null tumors in the untreated, that is dashed line state, versus the treated state, that's the solid lines, using again this strong immunotherapy treatment regimen of GVAX and PD-1. And we did this because the normal control tumors responded very poorly to PD-1, and we wanted to make sure that we could see a response in control tumors and then validate that it was lost in the beta-2M null tumors. And sure enough, that's what we did see. You can see the control tumors respond, albeit transiently, they all ultimately do grow out to this strong immunotherapy treatment regimen, but beta-2M null tumors hardly respond at all. We next looked at ADAR null tumors. This is our positive control experiment. Using strong immunotherapy treatment regimen, we got a great response to treatment. The untreated tumors grow out, albeit more slowly than controls. Strikingly, however, this sensitivity persisted following loss of beta-2 microglobulin, suggesting that loss of ADAR1 in tumors is sufficient to overcome this mechanism of resistance. This result was a bit surprising, actually, at first, as it suggests that CD8 T cell recognition with MHC-I in tumors is not in all cases required for the response to immunotherapy. It also raises the question as to whether it could be possible to target tumors that entirely lack high-quality CD8 T cell antigens. A lot of ongoing work in the lab is focused on dissecting the mechanism of this finding. And one of the first things we wanted to know is whether our antigenic vaccine GVAX, which was unsuccessful in translating to human use, was required for this response. This is actually pretty new data where we've treated with PD-1 alone and found that indeed you still get great responses in ADAR1 null tumors, even without the GVAX. To start to understand this mechanism further, we again looked in the tumor microenvironment, this time focusing on our beta-2M null compared to control tumors, and saw, as you would expect, increased immune infiltration, CD45 positive cells, but now focused on some of these MHC-I, non-MHC-I restricted cytotoxic populations. And these include granzyme B positive, CD4 positive T cells, and NK cells, with the hypothesis that perhaps these cells, which don't require MHC-I for recognition of tumor cells, may be involved in the phenotype we've observed. We've also begun to dissect the cytokine and chemokine drivers by which these populations may be recruited and activated. These graphs are from cytokine beta rays of beta-2M null and ADAR null tumors. The two prominent chemokines we've identified so far, CXCL10 and CCL5, which are both significantly increased in our beta-2M null, ADAR1 null tumors compared with beta-2M control tumors. Notably, Aaron Ring here at Yale has described a similar phenotype of being able to overcome the loss of MHC-I using a modified IL-18 cytokine that he designed. So this remains another possibility that we haven't yet explored. However, we think this type of study is important as articulating the general principles by which loss of MHC-I can be overcome could lead to new treatment approaches to target tumor-specific immune evasion mechanisms. In summary, I hope I've convinced you of several points. First, ADAR1 loss improves the response to immunotherapy. Specifically, it can overcome the lack of an inflamed tumor microenvironment and the loss of antigen presentation by MHC-I. Additionally, this phenotype is driven both by tumor microenvironment inflammation, mediated by MDA5, and sensitization to interferon, driven by PKR. Finally, and I think this may be important, tumor cells contain sufficient innate ligand to drive therapeutic inflammation if their innate nucleic acid sensing checkpoints are disabled. And what we think this implies is that there may be other similar innate immune checkpoints that limit the sensing of double-stranded RNA or of other nucleic acid ligands that we could think about as therapeutic targets. And really, those questions inform the rest of the work that the lab is doing. I've mentioned already a focus on double-stranded RNA and ADAR1. We're also applying functional genomics to try to identify other novel targets, really with the insight that we have to focus on turning on some of these pathways of double-stranded RNA sensing or tumor microenvironment inflammation. And then we're involved in human translation, doing kind of in-depth tumor microenvironment investigation across several different tumor indications. We're always looking for new collaborators there. And all of this comes under the rubric of therapeutically targeting the inflammation in the tumor microenvironment. In just the last couple of minutes here, I want to quickly mention some of the ongoing projects in the lab that I haven't talked about thus far. First, I mentioned just the project describing how tumor microenvironment inflammation can overcome the loss of MHC-I. This is being led by Jessica Wei, but she's additionally leading a project looking at human tumors and trying to turn these pathways on in ex vivo samples, as well as doing deep dissection of the microenvironment. Weiwei Guo is working on novel strategies to detect double-stranded RNA and to mimic the sensors of double-stranded RNA that we believe will be compatible with functional genomic screening and the identification of novel cancer immunotherapy targets. And finally, Yijun Kim, who is in the lab focused on the comparison of discordant response lesions, so responsive and resistant lesions, from the same patient, trying to understand novel mechanisms of resistance to immunotherapy so that we can focus on overcoming. With that, I want to thank everybody in our lab, as well as our collaborators and mentors here at Yale who have been fantastic. I also want to acknowledge Nick Haining, my former mentor, and Rob Manguso. Much of the work that I presented early derives from studies with them. And of course, our funding here at the Cancer Center and at the NIH and the Melanoma Research Alliance. With that, I will wrap up. Thank you so much for the chance to present, and I'm happy to take questions.
Jeff, thank you. That's just terrific work and really exciting. And we have folks can submit questions. We have one question. Mike Hurwitz asked, so given the response in ADAR1 knockouts in the absence of MHC class 1, do you think that's a function of CD4 T cells or NK cells or both or some other mechanism?
Yeah, I think that's a great question, and we definitely would love to know that answer. Best hypothesis now is that partially based on some of the work that Aaron Ring has presented and Marcus Bosenberg, NK cells could be an important player there. Certainly they're increased, and we started to see some cytokines and chemokines that may activate them further. But we don't even know for sure that CD8 T cells aren't important. That's an experiment we're doing now. We just know they're not recognizing the tumor, but could they be activated through cross-presentation or another means is another question that we're investigating.
And then, in related work, obviously, Akiko Osaki and Anna Pyle have been working independently on RIG-I, or RIG-1, I don't know which it is, but which obviously is not necessarily, related to the function of ADAR1. And how do you see those two sort of bodies of work relating?
Yeah, so this is a great question, Charlie. And actually, Akiko is one of my mentors here and collaborators, and we've talked about this. We are actually in the process of testing a RIG-I agonist with the in ADAR null and control tumor cell lines. And the colloquial way we thought about this is kind of as a maximum inflammation bomb, because what we've shown is that any interferon producing stimulus can trigger this ADAR null amplification of sensing. And so our hypothesis would be that if you initiate signaling through RIG-I, even if the RIG-I is not involved in the pathways we've described here, you basically create a massive amplification of interferon by further knocking out ADAR1. So that remains to be seen, but that's what I would hypothesize.
Yeah, no, that's interesting. It sounds like a great opportunity to look at that. Well, I want to keep us on time. So Jeff, thank you. I know there are other questions coming in and people should certainly reach out to you directly, Jeff, but thank you for a superb presentation. And let me now turn to our second speaker, Dr. Robert Bona. Bob Bona is a professor of medicine and hematology, and recently, the past year, joined us as the director of the benign hematology program, as well as the medical director of the Hemophilia Treatment Center. Prior to joining Yale, Bob was a founding faculty member and leader at the Frank Netter School of Medicine at Quinnipiac, as well as a professor of medicine at the University of Connecticut School of Medicine. And Bob, throughout his career, really has been a leader in the clinical care and sort of advancing work in hemostasis, thrombosis, as well as benign hematologic conditions. And we're really very fortunate, Bob, to have Bob now leading this section and sharing his work with us. So, Bob, thank you.
Thank you, Charlie, for that introduction and for the opportunity to speak today. Let me just share my screen here. So good afternoon, everybody. And what I would like to do in the next 25 minutes or so is discuss with you some of the advances that have occurred in the treatment of hemophilia. And what I hope to show you is that over the past 5 years, there have really been significant and substantial advances, which came in the background of really several decades of really only modest advances in therapy. So just as a brief review here, these are X-linked disorders, mostly affecting men, but can also affect women who might have low factor levels due to unequal X chromosome inactivation. Hemophilia A and B are deficiencies in factor 8 or 9, respectively. They're clinically identical disorders, and the severity of the diseases really relies primarily on the residual factor that is remaining in the blood, with those with severe and moderate disease having less than 5% of factor 8 or factor 9, and those with mild disease having a higher value. And morbidity and mortality is due to spontaneous and trauma-induced bleeding, including bleeding into joints, which can cause a hemophilic arthropathy, which can be quite disabling. And just the history of hemophilia treatment in the last century is seen briefly on this slide. And at the end of World War II, blood or plasma transfusions were used to treat patients. These were largely ineffective, as only small amounts of factor 8 or factor 9 could be transfused. In the 1960s, cryoprecipitate was discovered as a source of factor 8, and that quickly gave way to the use of factor concentrates, either factor 8 or factor 9, purified from the plasma of tens of thousands of donors. And of course, while this advanced care, it also exposed individuals to a number of viral particles, and hepatitis C and HIV became a very significant problem in this population. And then in the early 90s, recombinant factors 8 and 9 were produced. And for the developed world, where economically this was allowable, the treatment of hemophilia with recombinant factors 8 and 9 became really the standard of care up until very recently. There are now about 145 federally funded hemophilia treatment centers in this country, and of course Yale is one of those centers. And the therapeutic, the approach and clinical issues are outlined here. Patients with hemophilia can either be treated in what's known as on-demand or episodic factor replacement, which is the treatment with IV factor 8 or factor 9 to treat a bleed, or prophylactic therapy. Inhibitor development, that is an alloantibody directed against factor 8 or less commonly factor 9, is a significant problem for patients and may occur in 30 or 40% of individuals with hemophilia A and makes treatment very difficult. And the goals of therapy are really here to prevent any bleeding if possible, prevent joint disease, and optimize a quality of life for these individuals. And the infusion of factor 8 or factor 9 by patients is traditionally given at home intravenously. Patients from a very young age learn to start an IV and infuse factor 8 or factor 9. But because of the short half-life of these drugs, about 12 hours for factor 8 and 18 to 24 hours for factor 9, they need to be administered 2 to 3 to sometimes 4 times per week to keep the factor levels in a range that will prevent bleeding. So this is an onerous thing for patients to do, and any advances here would be greatly appreciated by them. So here's the obligatory coagulation slide that I would like to show to reinforce and emphasize the role that factor 8 and factor 9 have in blood coagulation. So what we're seeing here is the tissue factor initiated pathway and activation of factor 10 by tissue factor 7A, or activation by factor 9 to 9A by tissue factor 7A. And 9A is also able to activate 10 to 10A. So 2 pathways to get down to this all-important enzyme factor 10A. And in this latter reaction, factor 8 serves as a cofactor for the enzyme factor 9A to act on its substrate factor 10 and increases the rate of reaction hundreds of thousand-fold when factor 8 is able to align the substrate and enzyme on a phospholipid surface in the correct fashion. One other thing to mention about factor 8 before we get into some of the details of the advances is that factor 8 travels, if you will, in the blood bound to von Willebrand factor. The von Willebrand factor is seen here in this linear structure at the bottom. Factor 8 is the yellow diagram above. And the binding of factor 8 to von Willebrand factor enhances the half-life of factor 8 from about 2 hours to about 12 hours. So this is a very important interaction. And just to point out here, because this will become important later, is that the binding site on von Willebrand factor is these 2 protein domains designated D' and D3. And another important point is there appears to be a large portion of the factor 8 molecule termed the B domain, which is not required for factor 8 function. So you can remove that domain, and in fact, factor 8 has a similar activity than it does with that domain. So the advances in care of hemophilia really over the past 5 to 6 years come into 3 different areas. One is extended half-life factor concentrates, allowing for patients to infuse less frequently. The development of non-factor 8 or 9 therapeutics, and then gene therapy. And we'll go through these individually in the next 15 minutes or so. So the extended half-life products have been produced by manipulating the recombinant factor 8 or 9 in a number of different ways, many of which are familiar to you, by either adding polyethylene glycol or conjugating the factor to the FC portion of immunoglobulin or albumin to improve half-life, or in the case of factor 8, to remove that B domain, which causes a slight increase in the half-life. And there are now a number of products that have been approved for use that are extended half-life products. And I'll draw your attention to the last 3 on this list. These are factor 9 products, which have been manipulated by these methods seen here. And the half-life of these products has been extended from 18 to 24 hours to upwards of 90 or 100 hours. So this has allowed patients with factor 9 deficiency or hemophilia B to be treated once a week, once every 10 days, and in some circumstances, even once every 2 weeks. So a significant advance for people needing to give intravenous therapy to themselves at home. The advances in hemophilia A with factor VIII, however, are much more modest with this type of manipulation. And it turns out that the degradation in the catabolism and clearance from the circulation of factor VIII is much more linked to the clearance of von Willebrand factor, the protein that it's bound to. So making modifications in the factor VIII molecule has really had minimal effect up until recently on factor VIII half-life. So an interesting construct has been devised, and it's shown on the top panel here. And in this construct, the D' and D3 regions of von Willebrand factor, the binding region to factor VIII, is linked to an FC portion of an immunoglobulin and linked to the B domainless factor VIII molecule, which also has linked on it this hydrophilic polypeptide, which also can extend the half-life. So this product has been called BIV001 and was used to treat a handful of patients in a safety study, and those results were reported in the New England Journal of Medicine earlier this year. And patients were either treated at 2 different doses of this new product, and the factor VIII clearance from the circulation was compared to the typical factor VIII clearance seen in the lighter blue bars here. And what you can see, I think, is that the half-life of this newer product is now about 2 days, increased about 5 or 6-fold the half-life of the standard factor VIII product. So this product is now in large-scale clinical trials, and I think in the next year or 2, we should have some more information, and this may be an advance for some of our patients. So let me shift for a minute to the non-factor products for the treatment of hemophilia. And I think a significant advance has been made here. And there are 3 drugs that we'll talk about. We'll really focus primarily on this first drug, which is called emicizumab. And emicizumab is a bispecific monoclonal antibody that binds to factor IX and factor X. So it simulates the activity of factor VIII. Remember that factor VIII is able to co-localize factor IXA and factor X on a phospholipid surface. This antibody is able to bind factor IXA and factor X in the circulation and, again, simulate the activity of factor VIII. So this drug is not exactly like factor VIII. There are certain differences here. It binds to factor VIII and IX in the circulation, not just on the phospholipid membrane. It has different affinities for the substrate and enzyme, and whether or not that it becomes an issue for this drug, we'll only know as more experience is accumulated. But nonetheless, this drug has really shown dramatic activity. So this is a study that was published a few years ago in the New England Journal of Medicine. Here we had patients who have hemophilia A with inhibitors to factor VIII, so a challenging group of patients to treat, were treated either with their typical regimen of recombinant factor VIIa or factor VIII bypassing activity, or with emicizumab given by subcutaneous injection once a week. And the annual bleeding rate is been described on this slide here. And you can see, if we just look at these blue histograms for a minute here, the annualized bleeding rate in the emicizumab prophylaxis group was about 5 or 6, and it was almost 30 in the standard of care treatment of patients with hemophilia A and inhibitors. So a really significant advantage for these individuals. And then a second study was published with looked at patients with hemophilia A without inhibitors. And this was a randomized trial. Patients were treated with 1 of 2 doses of emicizumab, either given weekly or every other week by subcutaneous injection, compared with no prophylaxis, about 100 patients in the trial. And again, the annualized bleeding rate went from about 40 to about 1 or 2.